Atherosclerosis is no longer viewed strictly as a lipid-related disease. It is fundamentally an inflammatory process. High-sensitivity C-reactive protein hs-CRP has emerged as the most clinically validated biomarker to capture this inflammatory risk, serving as a critical tiebreaker in primary prevention and risk stratification. While LDL cholesterol initiates subendothelial injury, inflammation drives plaque progression and instability. The inflammatory cascade begins with interleukins, primarily interleukin 1 beta and interleukin 6, which stimulate the liver to produce CRP. Elevated hs-CRP indicates active macrophage infiltration within the arterial wall and the localized secretion of matrix metalloproteinases which thin the fibrous cap. Therefore, hs-CRP is not just a marker of plaque burden, it is a marker of plaque vulnerability and impending atherothrombosis. The primary value of hs-CRP lies in risk reclassification for patients where the decision to initiate statin therapy is ambiguous. In the ACC/AHA guidelines, an hs-CRP level of 2 mg per liter or more is officially classified as a risk-enhancing factor. In the low risk category, that is less than 5% risk of atherosclerotic cardiovascular disease, or high risk category, 20% or more risk of atherosclerotic cardiovascular disease, hs-CRP rarely changes management as the treatment path is already clear. Borderline cases 5% to 7.5% or intermediate risk 7.5 to 20%. A repeatedly elevated hs-CRP strongly favors the initiation of moderate to high intensity statin therapy. So the importance of hs-CRP in deciding management is mainly in the mid segment, not in the low risk or high risk group. Tools like the Reynolds risk score directly incorporate hs-CRP alongside family history to reclassify patients. This often identifies high-risk individuals, particularly women, who are frequently missed or underscored by standard lipid-centric calculators. Statins possess pleiotropic effects, meaning they lower hs-CRP independent of their LDL lowering capabilities. Tracking both parameters allows you to monitor both the lipid and the inflammatory response to therapy. Two pivotal clinical trials establish the clinical mandate for evaluating and targeting inflammation. Jupiter trial hypothesis: do statins benefit patients with LDL less than 130 mg per deciliter but high inflammation? Key finding: rosuvastatin reduced major adverse cardiovascular events by 44% in patients with LDL less than 130 mg per deciliter but hs-CRP 2 mg per liter or more. Candos trial: does targeting inflammation directly without lowering LDL reduce risk? Canakinumab, interleukin 1 beta inhibitor, significantly reduced MACE, proving the inflammatory hypothesis of cardiovascular disease. Because CRP is an acute phase reactant, it lacks specificity. To use it effectively for cardiovascular risk assessment, timing: it must be measured in a metabolically stable state, free of acute infection, trauma, or active illness. Confirmation: a single elevated reading is insufficient. Guidelines recommend 2 measurements taken at least 2 weeks apart, using the lower of the 2 values to guide therapy. Extreme elevations: values more than 10 mg per liter usually indicate an acute systemic infection or an active rheumatologic flare rather than baseline cardiovascular risk. These results should prompt an evaluation for non-cardiovascular causes.